I think we'll get started. Hi, everyone. I'm Victoria Kirsch, the National Scientific Coordinator of CanPath, the Canadian Partnership for Tomorrow's Health. Welcome, and thank you for joining today's CanPath webinar. Today, we'll hear from two researchers who will share how they use data from CARTaGENE, a CanPath regional cohort, to investigate the effects of depression and ultra-processed food consumption on both type 2 diabetes risk and the risk of developing diabetes-specific complications for those with type 2 diabetes. First, we'll hear from Dr. Norbert Schmitz, who is a professor and director of the Department of Population-Based Medicine at the Faculty of Medicine at Tübingen University in Germany. Previously, he was a professor in the Department of Psychiatry and Epidemiology, Biostatistics, and Occupational Health at McGill University, and a senior investigator at the Montreal Diabetes Research Center. His research is concerned with the relationship between mental disorders and physical chronic conditions. Recent research has focused on psychological, behavioral, and biological factors as risk factors for type 2 diabetes and risk factors for poor outcomes in type 2 diabetes. And then we'll hear from Dr. Akankasha Sen. She holds a PhD in human nutrition from McGill University. During her doctoral studies, she joined the Norbert Schmitz Research Group at Douglas Mental Health University Institute, where she developed a keen interest in exploring the behavioral factors contributing to the complex interplay between mental and physical health. Akankasha's thesis, titled Ultra-Processed Food Consumption, Depression, and the Risk of Diabetes and Its Complications in a Population-Based Sample, underscores her dedication to unraveling the intricate connections between diet, mental health, and chronic diseases within a population-based context. And we'll hear more about this research during today's webinar. So following their presentations, we'll have time for questions. Please use the Q&A button at the bottom of the Zoom window to drop your questions throughout the talk, and we'll get to them soon. Before we start, though, I'd like to acknowledge the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples, on which the CanPath National Coordinating Center at the University of Toronto now stands. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. With CanPath teams working across Canada from coast to coast, we also acknowledge the ancestral territories that are home to many Indigenous peoples from across Turtle Island, and we're grateful to have the opportunity to work on this land. So now I'll hand this over to Dr. Schmidt and Sen. Looking forward to hearing your presentation.
Thank you very much, Victoria, for your introduction. So I will share my screen. So I hope everybody can see it now. So again, thank you very much for having us here today to talk about ultra-processed food consumption, depression, and diabetes. So some of you might be surprised by the title, by the long and different subjects within the title. So ultra-processed food, depression, diabetes, so different topics. So what we would like to do today is to give you a brief introduction into what we did with the CARTaGENE study. And I would like to start with a general introduction of the topic. So why are we interested in this combination of different factors, and why it's important to study diet, food, ultra-processed food consumption, mental health, and diabetes? So why it's important and relevant, to give you some of the background for the next 10 minutes or so. So when we talk about diabetes, we know it's a prevalent condition, and a number of cases are increasing worldwide. So when we look here at prevalence of diabetes in 2021, we see high numbers in some countries, like in US, Mexico, and some countries in Africa. So it's different in the world, but we see that prevalence of diabetes is increasing worldwide. So when we look at the total numbers, so we see that by 2045, we expect that more than 700 million people worldwide will live with diabetes. So there's a rapid increase worldwide in a lot of countries. And when we look at Canadian context, so there are more than 3.2 million Canadians living with diabetes, and approximately 95% of those cases are type 2 diabetes in Canada. And again, the number is increasing, and within the next couple of years, we will see an increase in those numbers of people living and diagnosed with diabetes. So nutrition is an important aspect. Obesity, nutrition is an important aspect that contributes to diabetes. And there was an interesting study published a couple of weeks ago, actually, in the Lancet in February this year. And they looked at obesity worldwide and change in obesity worldwide. So the analysis was they combined more than 3,600 population-based studies with adults and adolescents and children to get an idea about the prevalence of obesity. And what I found is more than 1 billion people worldwide are now estimated to have obesity. So it's not about overweight and having a few kilograms too much. No, it's really about obesity for adults. It's a BMI above 30. So more than 1 billion people worldwide. It means 1 out of 8 would be classified as obese, which is a huge number and a big problem. So what I also reported is those numbers when we look at the change from 1990 to 2022. So the prevalence of obesity roughly doubled in women, tripled in men, and quadrupled in children and adolescents. So this is at a much faster rate than expected. So 10, 15 years ago, we would expect to see these numbers by 2030, but now we already see these numbers in 2021. So the increase of obesity is very high. And obesity is a very important risk factor and strongly connected to diabetes, type 2 diabetes. And it's connected also to diet and eating behavior. So it's an important topic we will have to work on from a public health perspective. So when we talk about diabetes, so what are modifiable risk factors for type 2 diabetes? So factors we know we can change. So there are a couple of them, and they're well known and well researched. We know socioeconomic status is an important factor. We know lifestyle is an important factor, unhealthy diet, physical inactivity, alcohol consumption, smoking, unhealthy sleep, but also metabolic factors, prediabetes, hypertension, dyslipidemia, and also mental health is an important risk factor for type 2 diabetes. So let's look for a moment at unhealthy diets. When we talk about unhealthy diet, this is a very broad term, what we consider as unhealthy diet. So it's like a big umbrella. So it means some people eat no vegetables or not enough fruits, or some people only have a very specific diet. So it's a very big umbrella term, unhealthy diet. So it's important, at least from research and from public health perspective, to have a better understanding or better definition of unhealthy diet. And one important factor that came up in the last couple of years was ultra-processed food, consumption of ultra-processed foods. So those are food that's typically high in unhealthy fats, sugars, and salt, and low in fiber and nutrients, like soft drinks, packaged snacks, products, prepackaged meals. And Akankasha will talk later a little bit more about this ultra-processed food. So it's one aspect of unhealthy diet, which seems to be very important and relevant. So what do we know about ultra-processed food and type 2 diabetes? So a couple of years ago, in 2020, there was a study, a French study published in JAMA Internal Medicine. So they looked at one of the big French cohorts. They had more than 104,000 participants included, and they used a 24-hour dietary record a couple of days, and they did follow up after 6 years. And what I found in the study that a higher proportion of ultra-processed food in the diet was associated with a higher risk of type 2 diabetes. So they're controlled for age, sex, education, BMI, physical activity, alcohol, family history of diabetes, overall nutrition quality. So even taking those factors into account, there was still an important association. People who had a high consumption of ultra-processed food were at higher risk within 6 years of being diagnosed or developing and being diagnosed with type 2 diabetes. And a couple of other studies have replicated this finding. So this is the first important piece. Ultra-processed food is associated with higher risk of type 2 diabetes. So there is evidence from research to show this link, this association. But then, as I mentioned before, we have mental health. Depression is associated with diabetes. So depression is a risk factor for diabetes. So this has also some tradition. And when I teach, I show always my students this quote. So diabetes is caused by sadness or long sorrow and other depressions and disorders. So as you might see and imagine from the wording, so this is not a very recent quote from a recent journal or from TV or somewhere. So it's a little bit older quote, and I always ask my students to guess when this was stated, and it goes back to Thomas Williams, 1650. So we know for a very long time that mental health is an important factor associated with diabetes, or increase the risk of developing diabetes. So there's a lot of evidence. We have a lot of studies, meta-analysis that summarize original studies, different meta-analysis showing depression increase the risk of type 2 diabetes. So there's substantial evidence here in this case. But there's one big problem when we talk about depression as a risk factor for diabetes and other conditions, chronic conditions. So depression is a very heterogeneous condition. It's some kind of artificial condition. It's not that we take a blood test and then we know, oh, this person has diabetes, has depression. So it's a convention of symptoms where people agreed. So there are specific symptoms that are indicators of depression, which makes it difficult sometimes to work with this diagnosis, because we have different symptoms and we have opposite symptoms for a major depressive disorder. So for some people, it could be weight gain, could be a symptom of depression. For other people, weight loss. For some people, increased appetite could be an indicator. For other people, decreased appetite. Insomnia, hypersomnia, or psychomotor agitation or retardation. So we have different symptoms for depression, which makes it very difficult to talk about depression as one unique condition. And that's a big challenge in research, but also in public health, to understand when and how depression affects health outcomes, or if there are depressive subgroups that are important, or when depression interacts with other factors, so which increasing the risk of developing poor health outcomes like diabetes. So this is a very important challenge we are facing. So what is the role of depression in the development of diabetes? Role of depression in the development of complications in people living with diabetes, and how does depression interact with other behavioral factors and lead to diabetes? So this interaction is really important. It's not sufficient to say, oh, someone has depression, so then we treat depression and then people will not develop diabetes, everything is fine. No, that's not the case. Depression is connected with other conditions, with behavioral conditions like diet, which interacts with those conditions, increasing the risk of developing diabetes and other conditions. So we know there are complex associations and no simple associations between mental health like depression, anxiety, stress, and chronic conditions like diabetes, metabolic syndrome, and heart disease. So we know there are behavioral factors that are very important, like diet, also physical activity. We know biological factors are involved in this process, but there are also individual factors, social factors, socioeconomic status, access to specific things, cultural factors, and environment, which are important in the link between mental health and chronic conditions. So it's really important to get a better understanding of those factors so that we can better treat or prevent onset of chronic conditions, or prevent onset of complications in people with chronic conditions like diabetes. So we also know there's ultra-processed food and depression are linked. There was a study from Australia recently, last year, a couple of months ago, showing high ultra-processed food consumption is associated with psychological distress and depression at follow-up, and a couple of other studies have replicated this. So consumption of ultra-processed food is associated with depression. There's increasing scientific evidence. So there are potential pathways, nutrient deficiency and brain functioning, chronic inflammation, but also psychological and social factors, stress coping. So we all know eating and poor diet is very often a way to cope with stress for people. So if they're very stressed, they have no time to eat for proper meals, so fast food, snacks, and managing with stress results sometimes in unhealthy eating behaviors and unhealthy diet. So we know this link, ultra-processed food and depression is there. And so what we're now interested in, so how work those factors together, depression and ultra-processed food, to increase the risk of developing conditions like diabetes. That's one aspect. So how does it work together to increase the risk of developing diabetes? But we're also interested in complications in people who have been diagnosed with diabetes. So if someone is diagnosed with diabetes, so they have to follow a proper management plan, and depression is associated with adverse outcomes in people with diabetes. So if people have depression disorder, there's an increased risk of physical complications, mortality, of poor glucose levels, and worsen adherence to self-care management. So a very important pathway. Depression affects self-care, resulting in poor functioning, which can in turn result in depression. So it's a very dangerous association between diabetes, depression, and complications. So what we really need to understand is, how do risk factors work together? So we really have to move away from this approach. Oh, we have identified one risk factor, so we provide an intervention for this specific risk factor and everything will be fine. No, it's not the way how it works. So we know risk factors, behavioral factors, mental factors, biological factors are connected in different ways. And we really have to identify how those factors are connected, and in order to provide better care and better prevention from a public health perspective. So that was the main idea of this project. Akankasha did here, using data from CARTaGENE to better understand. And here we focus on depression, or depressive symptoms, and ultra-processed food to get a better understanding of this interaction. So we are really interested in what is the association, combination of ultra-processed food and depressive symptoms as a risk factor for type 2 diabetes in people who do not have diabetes at starting point, and for those who have been diagnosed with type 2 diabetes. So what is the role of people who have both consumption of ultra-processed food and depressive symptoms? What is the risk of diabetes-specific complications in people with those diabetes? And so solution, there are not many ways to look at this, because setting up a study to look at this, a population-based study, takes a lot of time, is very expensive. And so we are very lucky to work with, to have CARTaGENE and to work with CARTaGENE, still one of my favorite studies, because here we have a great opportunity, at least as a starting point, to look at this association between depressive symptoms and ultra-processed food consumption, to see how this increases the risk of developing diabetes and poor diabetes outcome. So I will stop here and hand over to Akankasha. Akankasha, please go ahead.
Thank you so much. I'm just gonna share my screen. Okay. Can you see my screen, Professor Norbert? Okay.
That's good, yeah.
Thank you. I wanna use the laser pointer. Okay. So I'm set up. And I'll stop now. So thank you so much, Professor Norbert, for giving us very detailed introduction or background on depression and diabetes epidemiology and its association with ultra-processed food consumption. Before going in my presentation, I will present my results and methodology. But before going into my result and methodology, I want to talk a little bit about the nutritional transition and why we were interested in using ultra-processed food as one of our indicator of unhealthy diet. Okay, yeah. So according to Popkins, nutritional transition is defined as shift in dietary consumption and energy expenditure that coincide with the economic, demographic, and epidemiological change. There are 5 stages of nutritional transition. First is collecting food, second is famine, third is receding famine, chronic diseases, and 5th stage is behavioral change. At present, most of the nation around the world is stage 4 of a nutrition transition, which can be characterized by high consumption of fat, sugar, sugary drinks, shift in technology of work and leisure, and high level of inactivity, along with the high consumption of ultra-processed food, which can increase the risk of obesity and nutrition-related non-communicable diseases. Canada is one of the largest buyer of ultra-processed food and drinks in the world, and according to Canadian Community Health Survey conducted in 2004 and 2015, almost half of the energy intake is coming from the ultra-processed foods. And these are high, especially among in the young population, those with the less formal education, living in the rural area, and born with the indigenous identity. So therefore, we were interested in understanding how this ultra-processed food consumption in combination with the depression can increase the risk of type 2 diabetes incidence and its complication. My first study goal was to prospectively investigate the potential additive interaction between ultra-processed food consumption, depression on the incidence of type 2 diabetes in Canadian community sample. For this study, we are using the baseline data from the CARTaGENE health survey, that is a population-based prospective cohort study of Quebec resident age 40 to 69. And the sample was collected from 4 regions of Quebec, which were Montreal, Saguenay, Quebec City, and Sherbrooke. And participants provided detailed information on the physical measure, health questionnaires, other lifestyle factors, and also a subset of the population in phase A provided the detailed information on the nutritional component that I will talk later more in detail. And also, participant in CARTaGENE provided a consent that we can link their data with the administrative health database of the Quebec, which is also known as RAMQ. So based on this consent, we used the strategy that we linked our CARTaGENE baseline with the administrative health database to see the incidence of the type 2 diabetes. Depression were assessed using 2 indicators. So first, at the baseline, the depressive symptoms were measured using the self-reported patient health questionnaire 9. And this questionnaire consists of 9 questions related to vegetative, emotional, behavioral, and cognitive symptoms. And participants were asked to what extent they had experienced these symptoms at past 2 weeks, ranging from not at all to nearly every day. So score was created based on these responses. And in this study, we are using a score of 6 and higher on PHQ-9 as it's an indicator of a depressive symptom. And further, this score also has been compared with the structure interview for the major depressive disorder, and has sensitivity of 0.91 and specificity of 0.61. Further, we use another indicator for depression, which was antidepressant use. So at baseline, participants bought their medication, and reported their current medication use, and antidepressant use were classified based on the medication name. So these are the two indicators we use for the depression. First is based on the depressive symptom, and second was antidepressant use. For the dietary assessment, a subset of the population provided information on the Canadian Diet History Questionnaire. So this questionnaire is very detailed questionnaire, which consists of 165 questions related to food, portion size, frequency, nutrition supplement used during the past 12 months. So DHQ recorded a typical portion size for each item, and consumption frequency were measured into category ranging from 1 to 6 times per year to 2 or more times per day. So we calculated the daily consumption for each item, and the portion size of consumed item were converted into gram by using the nutrient database for Canadian Diet History Questionnaire. And we calculated the consumed amount by multiplying the frequency per day with the grams of consumption. After we calculated the amount consumed, we use Nova classification method, which I will discuss in detail now. So Nova classification method, what is Nova classification method? So this method classify all the food and beverages according to nature, extent, and purposes of industrial processing they undergo. So this method was first proposed by the team of investigators at University of São Paulo, Brazil, and led by Professor Carlo Monteiro. And later, this method has been developed and refined after much testing and consultation in many countries, including Canada, United States, Europe, and many Latin American countries. So now this method, Nova classification system, is recognized as one of the valid tools for nutrition and public health research. So Nova classification divide food into 4 groups, and the food processing as specified by Nova involve physical, biological, and chemical change applied to the food after they are separated from their nature and before they are prepared to cook to cooking and consumption. So the first group of Nova classification is unprocessed or minimally processed food, such as our fruits and vegetables, fresh and pasteurized milks, and meat products and fish products. Second is Nova Group 2 is the processed culinary ingredient comprised process such as salt, sugar, vegetable oil. These products are extracted and refined from the Group 1. And Group 3 is our processed foods such as fermented foods, cheese, and freshly prepared bread. And Group 4, which were the main group of our research, which is ultra-processed food and drinks that were prepared mostly or entirely from substance derived from industrial food and with a little or no whole food content. So we were interested in classifying the Canadian Diet History Questionnaire according to these food classification. So we use 4-stage identification process to classify these the food groups, food items that were in the Diet History Questionnaire. So first, we compile all the items in the Excel sheet, and then 2 independent researchers look carefully and classified the food based on the process degree of processing. And then the process were iterative, and we were consistent, iterative, and we also were consistent regarding the food items. And further, if there is a disagreement.
In path, Megan, to everyone, if we don't get to answer your question today, please reach out to CANPATH at info@canpath.ca. For researchers interested in accessing CANPATH data, please get in touch with access@canpath.ca.
So further, if there is a disagreement between the researcher, we looked at the literature to see how that food item was classified. So we use the 4-stage identification process. Our inclusion and exclusion criteria were as such. At phase A, we used the CARTaGENE data from the phase A, and we used the data with the we used the information on nutritional component only. So there were like approximately 7,000 participants who provided us with the nutritional data, and we removed the participant with the impossible energy intake, and also with the participant who self-reported diabetes at the baseline based on the question that whether doctor ever told you that you have a diabetes or not. So in total, we had total sample size were 3,880 individuals. We use survival analysis, and we use Cox proportional hazard model. And what strategy we did is that we created 4 groups to find the incidence of type 2 diabetes, and we used 7 years of follow-up. So 4 groups that we created were based on the presence and absence of high consumption of ultra-processed food and depressive symptom. So our reference group were those with the low consumption of ultra-processed food and low depressive symptom. And our other 3 groups were based on presence and absence of these factors. So we use 7 years of follow-up to find the incidence of type 2 diabetes, and we use International Classification Disease ICD-9 and ICD-10 to find the incidence in the RAMQ database of Quebec. Further, we did another additional analysis where we use our second indicator for depression, which was antidepressant use. So we combined 3 factors: high consumption of ultra-processed food, high depressive symptom, and antidepressant use. So we create the 4 group based on presence and absence of these factors to find the incidence of type 2 diabetes with the 7 years of follow-up. So here is the result of my first study. So baseline characteristic of my study sample were as such. So we found that on an average, sample was 54 years old, and we found that participants who were in the group high ultra-processed food consumption group along with the depressive symptom group had higher mean intake of ultra-processed food, which is 605 grams per day, and a total of 263 individuals, which is approximately 6.8, developed the type 2 diabetes during the 7 year of observation period. And this table is showing you the contribution of each food group to the total amount of ultra-processed food consumed. And we found that the highest contributor to the ultra-processed food consumption was soft drinks and isotonic drinks, such as energy drinks, shakes, soft drinks, cold drinks, and all the non-dairy beverages. Further followed by fast foods and ready-to-eat, and cookie, biscuit, and muffin group as well. First, we run our survival analysis on individual factors. First, we want to look at how these factors individually affect the incidence of type 2 diabetes. So we found that individual with the high consumption of ultra-processed food group has higher risk of developing type 2 diabetes, but no such association were found with the depression, with the 2 indicators of depression, which were PHQ-9 and antidepressant use. Further, we did a combined analysis where we created a 4 group, and we did not find any association when we use high ultra-processed food consumption and depressive symptom as an indicator of depression. However, in our second model, where we combined antidepressant use along with the depressive symptom and high ultra-processed food consumption, we found that this food group, which has high consumption of ultra-processed food, high depressive symptom and antidepressant use, has higher risk of developing type 2 diabetes incidence compared to the other groups. My second study wants to understand how the interaction between ultra-processed food consumption and depression can increase the risk of diabetes-related complication in adults with type 2 diabetes. So we used the same strategy. We had the baseline CARTaGENE data that we linked it with the administrative health database to see the incidence of diabetes complication this time. So our study 1 and study 2 is different in this aspect. In study 1, we had the participant without diabetes at the baseline, and in study 2, we have the participant with diabetes at the baseline. And in study 1, we have more female participant than the male, and in study 2, the proportion of male and female were same. Our measure was same. Depression was assessed using patient health questionnaire 9 and antidepressant use, and Canadian diet history questionnaire were used to classify the food based on the NOVA classification system. Our outcome of interest was microvascular diabetes complication and macrovascular diabetes complication that we assessed using International Classification Disease, ICD-9 and ICD-10. And here is the inclusion-exclusion criteria. So we had from phase A, we had 7,000 people who give us information on the nutritional component, and we used there were only 880 approximately participants with the diabetes with diabetes at the baseline, and we excluded the participant with a possible energy intake, leaving us with the 683 sample size. We used the same model. We used Cox proportional hazard model, and we created 4 groups based on presence and absence of high consumption of ultra-processed food and high depressive symptom, and 7-year follow-up were used to find the incidence of type 2 diabetes complication. So we combined the micro and macrovascular complication as a one outcome. And we did a further sub-analysis as well, where we used a 2 indicator of depression, which was another indicator of which was antidepressant use along with the depressive symptom. So 4 groups were created similarly with the presence and absence of high consumption of ultra-processed food and low consumption of ultra-processed food, along with the high depression and low depression. So here are the baseline characteristic of my of the study sample. Mean age of the sample was 55 years, and a total of 105 individuals developed diabetes-related complication. Participants in high ultra-processed food group and high depressive symptom group had a higher mean intake of ultra-processed food consumption and a BMI and higher BMI as compared to the other 3 groups. And this pie chart is showing the contribution of each food group in the total amount of ultra-processed food consumed. And similarly, in this sample also, higher consumption was coming from soft drink and isotonic drinks, followed by fast foods and biscuit, muffin, and cake groups. So first analysis we did was individual association. So we did not find any association with the ultra-processed food consumption, PHQ-9 score, and antidepressant use. However, when we combined these factors to see the additive interaction, we found the association in, we found that in model 2, where we combined high ultra-processed food consumption with depressive symptom calculated by PHQ-9 and the antidepressant use, has a higher risk of developing type 2 diabetes complication as compared to other groups. So overall conclusion of my results were that individuals with co-occurring depression and high ultra-processed food consumption may represent a group at risk of type 2 diabetes and its complication. And further, in clinical practice early management and monitoring of both risk factors might be an important step in the diabetes prevention strategy. There is also limitation related to my research. First is that the food frequency questionnaire, which is a diet history questionnaire, were used to capture the nutrient information. However, the food frequency questionnaire is subjected to recall bias, and also individual report the food based on the social desirability. And further, there's also limitation with the administrative database, which is that we do not have information on the individual who leave the province and opt for the private insurance. And also the CARTaGENE respondents were also limited to mostly white participants. Therefore, the generalizability of our results should be made with the caution. And based on my research finding, my research also has implications for both research and policy. First is that my research finding emphasized the importance of identifying individuals at higher risk of type 2 diabetes, particularly those with the high ultra-processed food consumption and depression. And further, policymakers should consider implementing regulation related to marketing, advertising, and labeling of ultra-processed food consumption, seeing its rise all over the world. And integrated care model that incorporate mental health treatment and address behavioral risk factors such as unhealthy eating, such as ultra-processed food consumption, should be considered. I would like to thank first and the study participants of the CARTaGENE study that provide us their valuable information to make this study happen, and the CARTaGENE and CanPath for giving us the opportunity and platform to show us our result, and School of Human Nutrition, McGill University, and of course my fantastic supervisor, Professor Norbert and Hugo Melkar, for giving me a stage to perform my research at this level. Thank you so much.
Great. Thank you very much. That was a wonderful presentation. I think your work is really an excellent demonstration of how we can use a cohort like CARTaGENE and more broadly CanPath to really advance science. And I like the way that you really made use of all of the different data sources. You had the food frequency questionnaire, you were able to use the medication data, to help classify people as having a mental health issue. And then really interestingly, you used these linkages to the administrative health databases so that people didn't have to be followed up actively, but they could be followed up passively in order to capture these, incident cases of type 2 diabetes. And I think it's really, one of a powerful feature of, the Canadian healthcare landscape and these cohorts, that we have this ability to link to all of this health data. Okay, so we do have a couple questions rolling in. We have a question from Cindy Lawley. She's interested in understanding if either of you have any concerns or optimism around the use of GLP-1 agonists in type 2 diabetes and obesity. So in particular, she's wondering how we could use CanPath or CARTaGENE to advance our understanding of psychiatric risks versus the benefits of such therapies.
Maybe I can respond quickly. So we only can use studies like CARTaGENE. It's an observation study, so we cannot evaluate interventions or treatments. So what we can really get is what are general associations and what are interactions of specific factors, but we cannot evaluate a specific treatment. There we really need a clinical study where we have a more detailed assessment. And even for a study like here, when it comes to mental health, so we have to keep in mind for CARTaGENE baseline, so people had to come to the study center and for an assessment. So if someone had a major mental health problem at baseline, probably they were invited, but they didn't show up for the baseline assessment. So this is a really a limitation, that we don't have access to people like in a clinic, in a clinical study, or in a hospital. So it's a community sample, and we might miss some important people who have severe mental conditions. Same for diabetes. Those with diabetes, which is not well controlled, maybe that didn't come to the study, did not participate in the study, the more severe cases. So this is always a limitation. What we can get with those kind of studies is a general understanding about how different factors work together and how things develop over time. And I think it would be too much to ask for specific information on a specific condition here at this point.
Perfect, thank you. Alan McCormick is wondering if you could take a stronger stance on policy. So he writes, since ultra-processed foods and drink products now dominate the food supply in high-income nations, including Canada, and their sales and consumption have been steadily increasing in lower, middle, and middle-income countries, could we tax them or outlaw them? You know, what are your thoughts?
Yeah, would you like to?
Yeah. I just want to share this that yes, we do know that all around the world the consumption of ultra processed food and drinks is increasing widely, and many nations they are using different strategies to curb this global rise. And I know that many nations already implementing the similar classification system on the food and beverages, similar to NOVA, but not very similar. Such in I know, like in the Chile and many European countries, they already start using the red light system, where you can like identify which food is red light and which is a green light food, and then you can make like a conscious decision. The information is there that you can understand very clearly whether you want to consume it or not. And further, in Canada, food industry has given the time until January 1, 2026 that we will start seeing the similar type of classification system that will use like a white and green front. It's called front of packaging nutritional symbol, that we can see and which food is high in sodium, which food is high in fat, and which food is high in sugar. So the information will be there, and we will find that which food will be beneficial for us to eat because of this front of
Dr. Victoria Kirsch is the host now.
Labeling.
Mm-hmm. Yeah. I think what is very important, we have to find some kind of mix of strategies.
And Pat Megan is the host now.
It's not one single strategy that works. So taxing is probably an important aspect, but the labeling of food is another important aspect, and education probably is very important. So we have to start with education on those topics at a very early stage, in probably before school, kindergarten, school. So education and the combination of the different prevention strategies, one alone does not work. So if we say, oh, it's not allowed to use this products anymore, if it's forbidden, it's more attractive for some people. So like we see with the smoking ban in New Zealand, it didn't work at the end of the day. So we really have to find a mix of strategies, and education, I think, plays a key role in this concept to deal with this epidemic of obesity and ultra-processed food and things.
I agree with Professor Norbert that a mix of strategy is needed to, which is like a fifth stage of nutrition transition. Is like a behavioral change where we have to change our behavior to curb these nutrition-related non-communicable diseases that is on rise in the world at present.
Okay, thank you. Shiraz Chima is wondering if your measures and assessments also took into consideration any medication-induced weight gain, which is often a side effect of these medications used for mental health issues.
We do know that this is one of the, thank you for your question, and we do agree that this is one of the side effects of medication. However, we did not have the information about it that we can control for. So we did not include it in our control model.
Okay, and then we have a question about another variable, whether or not you were able to control for it. Did you also consider the family history of diabetes in your data set? Do you think that that factor can also affect the result?
Yes, diabetes, family history is also important risk factor. However, there is no such information were present at the CARTaGENE baseline for us to control for.
Yeah, family history is important, but what the evidence so far is, it's probably not the genetic factor. Genetic factors play a role in family history, but it's probably more the learned experience behavior within families, which is very important. So people if someone has a poor diet, parents have a poor diet, follow a poor diet and a poor lifestyle behavior. So it's very likely that not everybody, but a substantial number of children adapt those behaviors and use them later on. So genetic factors are one side which are important in this context, but the behavioral factors and what the children learn in families is very important. And again, it comes back to educational level. So education is such a key component in reducing those unhealthy behaviors.
Okay, Hiroshi Mamaya has a question related to your comment about the generalizability of your findings. You mentioned that CARTaGENE cohort is mostly a white population. Also, it seems that those who took the nutrition assessment represent a small proportion of the overall cohort. Was the nutritional assessment random? And if not, are we able to claim that the findings are applied to or are representative of the entire population of Quebec? Was there weight for sampling design and selection in the nutrition assessment questionnaire?
The questionnaire was sent to all the participants for the phase A. However, only 7,000 participants responded to the nutrition transition question, and between that, they were mostly white population. So I don't know if I understand the second part.
There was no systematic difference between those who responded and those who did not respond. So there was no that only people who had a good diet responded. I think one of the reasons was it was a very long questions with 160 questions.
Right. Yeah.
People already had to do a lot of respond to a lot of questions. So far, what we've seen, there was no evidence that there was a substantial bias. But yeah, again, it's a reduction, and but it's very difficult in this area of research to get a good assessment of consumption of ultra-processed food. Food frequency questionnaires or other tools are really needed, but if they have 160 questions, a lot of people are not very interested in participating. So for the future, we have to think about different strategies. There are some approaches where people take pictures of their meal. Now in the smartphone age, it's one strategy, or to come up with a somewhat better assessment. This is still a challenge to get a good assessment of ultra-processed food.
Right, but I think you demonstrated that you still were able to capture, heterogeneity in ultra-processed food consumption. Your highest category, if I recall, it was over 600 grams per day. So is that considered still high consumption?
Compared to the
other populations?
Compared to those other group, so the individual with the high ultra-processed food consumption and depression has like 600 grams per day. However, the one with the no these factor has like 100 grams per day. So when we compare between these groups, we can say that this is higher than the other ones. However, we did not compare with the other cohorts. We just did the comparison within the groups of our study.
Okay, perfect. Jenya Polsky said, great presentation, thank you. Wondering why you chose to measure UPF intake in grams per day rather than percent of calories. Also, Nova classifies industrial prepared bread as UPF, and she didn't see that among your subgroups.
So first question, I was interested in you understanding how the ultra-processed food group alone can increase the risk of type 2 diabetes and its complication. Yes, we could have done the percentage coming from the ultra-processed group. However, we did not take that strategy. We used the other route. And we do agree that with her Pulaski comment that freshly prepared, industrially prepared bread was considered Nova 4, and I did, maybe it's not clear, it's merged in all the groups, so that's why they did not say it, but it's considered in the Nova 4 group of Nova classification.
Okay, so I was wondering that as well. So were you able to distinguish between so breads or cookies or cakes that were made at home as opposed to, packaged?
It was a little bit challenging because there was not very great information, because the food frequency questionnaire asking direct question, right? So sometimes they have like the brand names. Are you using this type of brand bread? Are you using these brands cookies? So that's why we make the distinction. But there was not a clear, the question was not there whether you are making it at home or you are making it, you're buying it from the market. So there was not clear distinction between these two.
Okay, thank you so much. I think we're at the end of our questions. Yeah, there are no further questions from our audience, but if something comes to mind, contact us at CanPath. The slides from today's webinar, along with the recording of the webinar itself, will be posted on the CanPath website. Thank you so much, Drs. Schmidt and Sen. It was great hearing from you and hearing about your important work. And thank you for the great presentation. And thanks everyone for joining us today.
Yeah, thank you everybody for joining, and thank you very much for having us. So I think it's always a great experience working with the CARTaGENE cohort, and using allows us to look at those kind of questions which are not very difficult to assess or evaluate, despite all the limitations we mentioned here. But I think it's still a very unique and great cohort to look at those questions in much more detail, and which can be very stimulating to starting a new research ideas and new research, but also relevant for policies and for public health. Thank you very much for giving us the opportunity to present here.
Thank you so much, Thane. Thank you for giving us the opportunity and platform to present our research. And it's always good to present in a bigger audience and get the different questions, which you always find it interesting to look into it. So thank you so much.
Okay, bye everyone.
Bye.
Bye.